Poor line.
No line. Yeah.
All right, we're ready to go. Hi, good evening, everyone. So thank you for tuning in to Every Breath You Take Series 3. And today we're going to talk about journeys to the recovery, and we're going to focus on surgery and as well as radiotherapy. And with us today, we have Dr. To and Dr. Darren, both oncologists. And also we have Dr. Anand, who's a cardiothoracic surgeon. So I'm handing over to Dr. Murali to initiate the conversation. Yes.
Okay, thank you, Kenneth. A very good evening, ladies and gentlemen. I hope you're hopefully sitting down to an early dinner, or you still are nursing your teh tarik or kopi or whatever it is that you have in your evenings, your choice of poison. So we're coming back to you with the third installment of Every Breath You Take, which is really an education awareness kind of session on lung cancer. And if you recall, during the first two episodes, we looked at actually signs and symptoms of lung cancer, and then we looked at diagnostics, like how you're actually going to pick the disease up. Now, the thing is, as we go into the third segment, we're going to try to look at, once you have the disease, what are you actually going to do? And as usual, we're very fortunate. We've got three very, today actually more so, we've got three very eminent specialists in their field, and we generally have the cutting man, and then I'll call them the treating man. Very misnomer, forgive the generalization. So the cutting man, Dr. Anand Sachidananda, I think needs no introduction. He's a cardiothoracic surgeon and co-founder, president of Lung Cancer Network Malaysia. And together with Dr. Anand today, we have Dr. To Laiman and Dr. Darren Teo. Dr. To, again, no stranger to this series. We have been fortunate to get Dr. To quite a bit on these sessions. Dr. To is a consultant clinical oncologist, and he's also co-founder of Lung Cancer Network Malaysia. And from Red Zone, we have Dr. Darren Teo, who really, I think, is the most important person amongst us today, who's really taken time off to amidst, like, you know, this crisis, to kind of look at discussing with the rest of us about lung cancer. And actually, I don't know, I'm probably putting words into Dr. Darren's mouth and saying, look, I mean, it underlines how serious this problem is. Amidst COVID, you know, cancer still is a problem that continues to creep around and you know, afflict our society. So without further ado, I'm going to get Kenneth to kind of throw up slides and then kind of lead the cutting edge. If I could perhaps put a naughty pun on it, will be Dr. Anand, and I'm going to really throw it to Dr. Anand. Doctor, so as now we are in this session talking about someone who's picked up lung cancer, and traditionally we always look at how do you cut the cancer out of your body is always the kind of question that we ask. So perhaps in terms of lung cancer, what are our options? What do we have that we can offer to the patient?
Yeah, good evening, everyone. Thanks, Dr. Murali. So quite like the word healing man rather than cutting man, but jokes aside. I think as everyone knows, right, with lung cancer, as with any cancer, we've got 4 stages, stages 1, 2, 3, and 4. And as a general statement, when we're dealing with early stage lung cancer, stages 1 and 2, then the treatment of choice is usually surgery, provided the patient is fit enough for the operation. It may be surgery in isolation, but quite often it is in combination with other treatments. And usually for the more advanced stages 3 and 4, locally advanced and metastatic disease, stages 3 and 4, then there's a much smaller role for surgery, certainly not with a curative intent. So in terms of surgery for lung cancer, basically the objective in early stage disease is to cure, and we aim to do this by removing that part of the lung which contains the primary tumor. And in addition to that, the surgeon should also endeavor to clear out all the lymph nodes as well, what we refer to as systematic lymph node dissection. And just broadly speaking, surgery for early stage, we refer to this as a lung resection. And as you can see from the infographic here, there are various types of lung resection. The gold standard would be what is, perhaps Kenneth can just highlight that, we call it a lobectomy. So perhaps we just take a step back and look at the basic anatomy of the lungs. I'm sure everyone appreciates we have a pair of lungs, right and left lung. The right lung has 3 sections to it that we refer to as lobes: an upper lobe, a middle lobe, and a lower lobe. And they are separated by what is known as fissures, an oblique and a horizontal or transverse fissure. So these are separate functional units, but in essence, they are part of, they all make up one lung. On the left, our lung is slightly smaller in that we just have 2 lobes and 1 fissure. So we have an upper lobe and a lower lobe. So in terms of primary lung cancer, which is what we're talking about today, or early stage disease, the gold standard treatment in terms of surgical resection, an operation to remove the tumor, the gold standard is a lobectomy, which we refer to as an anatomical resection. So the surgeon will endeavor to remove that part of the lung, that lobe where the tumor is located. And this has been well validated for a long, long time. This confers the best chance of long-term survival and the best chance of a cure for the individual patient. As I mentioned earlier, the other important thing is to dissect out and remove all the associated lymph nodes. So if we look at the diagram starting from the extreme left, we have something referred to as a wedge resection. And the way I describe this to patients in the clinic is, if you think about it, if you go to Starbucks or Coffee Bean and you get a slice of cake. So wedge resection is pretty much taking a little wedge, a slice of the lung tissue. And we just remove the tumor. This is an option usually when you're dealing with very small tumors that are more peripheral in their location, meaning they're located at the outer edges of the lung. It is referred to as a sublobar resection or a wedge resection. And we often consider this as an option in a patient who may have borderline lung function. So, someone whom we feel may not tolerate removal of an entire lobe. So perhaps a very elderly patient, someone with a lot of other comorbidities, someone with poor lung function. We also sometimes do something called a segmental resection or segmentectomy, which is a wedge resection. The Americans refer to this as a wedge resection with vascular control. It's an anatomical resection. But really, Dr. Murali, the gold standard is a lobectomy. This is what we should aim to do if we set out to do an operation, a lung resection with a curative intent. And occasionally, thankfully less so these days compared to in the past, occasionally we have to remove an entire lung, and that's referred to as a pneumonectomy. And this would be in a situation where a patient has a large tumor, a central tumor. That means it's more towards the middle. It's closer to the main airway, closer to the major blood vessels. And for technical reasons, it is not possible to remove the tumor through a smaller resection like a lobectomy or a wedge, and it would necessitate a pneumonectomy. So that's a big undertaking. And it's important that we recognize that the reality is you only need one good lung to survive. So it's something that we do perform occasionally when required. Sorry, we can't. Can you guys hear me?
Yeah. I've just got one question, and this is increasingly, again, something which a lot of people tend to think about these days. And maybe Dr. To subsequently or Dr. Darren can help us with this, because a lot of people now think less is more. So I think an important point that you're making is that the lobectomy is the gold standard. And is it now, with the advent of, say, much more efficacious therapy and all that, can we opt to say go for a wedge and then hit it with radio or chemo? Is that something which can be done these days? Because a lot of people feel a lot of love for their body parts.
Perhaps I can just mention as well, we're trying to give a general overview in terms of lung resection. There are a lot of variables as well. You know, if we look at the, obviously you have to look at the patient in terms of their fitness for the operation. And importantly as well, we look at the histology, the cell type. So there are certain subtypes of lung cancer. If you have an adenocarcinoma, which is a type of non-small cell lung cancer, and there's a subtype of that called a BAC, bronchoalveolar carcinoma, subtype of adenocarcinoma, which has been shown to be perhaps a more favorable type of lung cancer. And there may be a role sometimes to perform a lesser resection, as you say, less is more, a sublobar resection like a wedge or a segmentectomy, with the idea to preserve more lung tissue. But really, I would say that as a general statement, you know, the important message we want to get out there is if a patient or a person has a primary lung tumor and it's early stage and they are fit enough, you know, there's a wealth of evidence out there. As of now, the standard of care is still a surgical lobectomy to remove that, because it confers the best chance of long-term survival, best chance of a cure. Perhaps I can just elaborate a little bit as well before we move on to my oncology colleagues and talk about radiotherapy. In terms of the approach, would you like me just to highlight that as well, Dr. Murray?
Yes, for sure. For sure, please do.
Okay, so I think you're right. I mean, you know, patients and caregivers are understandably concerned, you know, about removal of the lung. I always explain to patients, unlike the liver, the lung doesn't regenerate. What is gone is gone. But as I said previously, if we have one good lung, that often is adequate for a good quality of life. Obviously, you need to take care of that one lung if you're unfortunate enough to require pneumonectomy. Now, in terms of the surgical approach, I'm trying to highlight this. I think Kenneth's got to do that. The figure at the bottom on the extreme right. So this shows conventional surgery, which either way, whether we do conventional open surgery or a less invasive, or the term is minimally invasive approach, either way, we are talking about general anesthesia. It is exceedingly rare for this surgery to be done on an awake patient. There are 1 or 2 centers in the world which have attempted that or performed that. But really, we're talking about general anesthesia. You're fully asleep. And the conventional approach is through an incision in the side of the chest, what we call as a thoracotomy. And it affords very good exposure and access for the surgeon to get to the lung and to perform the operation. It is the most tried and tested method. In recent years, there's been a trend towards a less invasive approach, what we refer to as a VATS, VATS, video-assisted thoracoscopic, or a less invasive approach. And again, this is also an excellent option in appropriate cases, partly determined by surgeon experience and comfort level, partly determined by the anatomy of the individual patient. The obvious advantage is we're dealing with, you know, if you're able to accomplish that through a smaller incision, it's more cosmetic, slightly less tissue trauma, and that should translate into less pain, quicker recovery, shorter hospitalization. And in the context of lung cancer, that can be relevant as well, because if the patient were to require further treatment after surgery, adjuvant chemo, radiotherapy, immunotherapy, they may be in a better shape, better condition to avail of that more quickly. But I think it's very important that this decision is individualized based on the patient anatomy, based on the tumor anatomy. What is most important is the surgeon has to remove the tumor completely. You need to get what we refer to as clear margins, complete removal of the cancer. And he or she should endeavor to perform what we call a systematic lymph node dissection, clear out all the lymph nodes. Again, a lot of data, a lot of evidence out there to say this is the most efficacious method, best chance of long-term survival and a cure. So the surgical approach advances have occurred over the last 5, 10, 15 years. And the amount of lung tissue that's removed is essentially the same. It's just the approach that may vary.
Mm-hmm. Mm-hmm. And what is this? I think that kind of puts up the exact. I think you've tried to kind of put up that point in the next slide. I think where really when we speak about this balance for each patient, and probably it's a good time to kind of pick your mind on this a little bit. As in each patient's individual, you were saying. So what are the things that you really think about when you actually consider how to go in, how much to go in, what to cut, how much to cut.
Sure. So I think you're right, Murali. I mean, none of us, no two people are the same, and certainly no two tumors are the same. And as a thoracic surgeon, or for that matter, any surgeon dealing with any cancer, including lung cancer, the surgeon has to basically, it's very simple. We just need to answer two key questions. One is we need to ascertain the operability of the patient, and the other is we need to establish the resectability for the tumor. So these terms are sometimes used interchangeably and incorrectly by patients, families, even by doctors, but they actually mean very different things. So as I've highlighted there, when we talk about operability in simple terms, what we're referring to is the patient's fitness to undergo anesthesia and the required operation. And for this, we obviously need to see the patient. Over time, as you acquire experience, sometimes you have what we refer to as an end of bed assessment, or in the clinic, you just have a feel. But we also rely on some objective measures. So, we look at the chronological and biological age of the patient. We look at their nutritional status. We look at their cardiovascular status. Often they would have an echocardiogram. A lot of lung cancer patients may have had a history of smoking. They may have concurrent coronary artery disease. So an echocardiogram is usually a bare minimum baseline investigation. And we will certainly do lung function testing, where we get them to blow into a spirometer and measure the lung capacity, functional capacity. And we do certain calculations and make certain assumptions to see whether, if we were to remove a third or half or an entire lung, would this patient tolerate that? So what we call as a predicted post-operative measurement. And we look at the performance status, which is something I think the oncologists are very good at, because they tend to deal with more advanced stage disease. We got to make sure this patient is likely to survive the operation, and avail of the post-operative physiotherapy and have good social support. So that's the operability. The other important point is the resectability. So here, in simple terms, as a surgeon, we would ask ourselves, hey, can I remove this tumor? Can I get it out, and can I get it out safely? And for this, we rely on the international staging, the TNM, looking at the size and location of the tumors, the lymph nodes. And this is where the investigations are important. Your chest X-ray, your CT scan, occasionally an MRI, and certainly the PET scan. And sometimes resectability in borderline cases, you have a big tumor that is near important structures. Sometimes that can only be established at the time of the operation. Certainly if you want to give the patient the benefit of doubt. So the resectability is whether we can remove the tumor. And that's a technical evaluation, whereas the operability is to assess their fitness. We could have identical tumor in two patients. One could be a 40-year-old fit chap who, plays golf twice a week. The other could be an 85-year-old lady who's quite frail, who lives alone, has had a couple of previous strokes, has irregular heartbeat, is on blood thinners. So same tumor, two different patients. Operability could vary.
Right, and I think that's really the discussion that a lot of people neglect to have. We always tend to kind of generalize, and then we always say like, oh, my 70-year-old grandmother, and compared to my 35-year-old cousin. And so this operability versus resectability really is a fluid kind of condition, which depends on each patient. And it's important really that the patient, the family members, the decision makers discuss together with the doctor as to the viability of going into such a surgery. And so I basically was thinking about this in a more simple term of operability is basically how bad are you, and resectability is basically how bad is the cancer, kind of idea.
Very much,
right?
Yeah.
But also I think one of the points that you brought up was how now it's no more one person just looking at you. I remember we used to laugh when we went to medical school. We had legendary physicians who can just look at you and then you won't survive the operation. You can survive the operation. This kind of stories that you would hear. But now it's more and more becoming like a team decision, right? And as we were speaking earlier, and perhaps now's a good time to kind of get Dr. To or Dr. Darren to kind of come in to tell us that from which point or from what part of the process do the oncologists kind of come in? Dr. Darren, maybe. What do you think, Doctor?
Can you repeat your question again?
So as in now, is rather than it being an individual kind of segmental process, you finish the surgery and then only you get tapped out off to go and see the oncologist. That doesn't happen now, does it? When do oncologists come in from the get-go now in kind of planning the care for the patient?
I think you're quite right. I think the important things are to have a multidisciplinary team to assess every case right from the start and decide where do things go. And you can see in the next slide what needs to be done before surgery, what things need to be done after surgery, so that the patient is completely clear what is the plan of the entire treatment. Because as we all know that treatment for cancer involves many different modalities. That means treatment types: chemotherapy, immunotherapy, targeted therapy, surgery, and which order of these things go. B before A or A before B. And so these are the things that we all need to sit down, and each patient is individualized because each patient is different, both on fitness level, both from the location of the cancer and the extent of the cancer. So that's so important. Thank you.
Right, and Dr. Darren, to kind of, I think you brought up quite an interesting point, which is nowadays, and I think that's what the slide that we've kind of put up says as well. It's not necessarily that you only will get chemo or radio or whatever it is that the choice of treatment is in like after surgery. It can happen before surgery as well, can it, doctor?
That's right. There are so many permutations and combinations that can be done. And often treatment is now given before surgery. And in a lot of cancers, including lung cancer, before surgery, there is chemo and radiation has been standard of care for many years. And now there are many studies looking at whether immune therapy can be used before surgery. And that has been something that has taken off. It's not standard of care yet, but certainly something to look forward in the future. Thank you.
Right. Dr. To, sorry, I was just kind of, going to ask you on actually why do people want to do chemo or radio before surgery? Yeah? What is this? Isn't it better to just wait, cut first, remove all the tumor, and then, you're going to get whatever's left behind? What do you think, doctor?
Yeah, so systemic treatment before surgery is termed neoadjuvant treatment. That means giving a chemotherapy or immunotherapy before the surgery. There are two reasons for this. The first being that sometimes the tumor may be a little bit big for the surgeons to attempt to resect successfully. So even if they go in and try and remove the tumor, it may be stuck to certain critical organs or near certain structures which they are unable to treat or unable to cut. So if we manage to shrink the tumor, it allows the surgery to be performed successfully. Secondly, some of these tumors, they like to spread, and they like to spread very early, even before you are able to have the surgery. And if the patient goes for surgery and delays the treatment for these cells that have already run away, let's say they run away and hiding in the liver or the bone or other parts of the body, then you allow them chance to grow and spread even further. So maybe it's better to try and kill off these small cells, and then the surgeon can go in and remove the big mothership. So kill the small ships, and then the mothership is dealt with later on. And then that's similar to the reason why we give treatment after surgery. So even though we've removed the mothership, the satellites may have spread outside elsewhere. So we follow up surgery with some chemotherapy and immunotherapy, or even targeted therapy nowadays, to wipe out all these small cells which are left behind.
Right, and perhaps Dr. Anand, that means in terms of going back to that slide earlier, when you speak about a highly non-resectable tumor. How often, and this is just curiosity, how often that when you then use neoadjuvant therapy, does the tumor actually become resectable, or it goes more resectable after kind of the neoadjuvant treatment?
Well, I mean, you know, the landscape for lung cancer management continues to evolve. Very, very exciting. And what what Dr. Darren and Dr. Thor can provide as oncologists up and down the country, you know, there's a lot in the armamentarium. So as what Dr. Thor was saying, the main key with neoadjuvant is the term is downstaging, you know, to optimize or give the surgeon the best possible chance to fully remove the tumor. And numerous cases we've had, you know, where we're able to get a good downstaging. The tumor is still there. It becomes technically, although neoadjuvant therapy makes it more sticky and it's also more challenging surgery, you know, it's a bit more sticky, it's a bit more, the risk of bleeding is a little bit more elevated, but it does what it's intended to do, which is to shrink the tumor, downsize it, or irradiate or kill off the cells in the lymph nodes, as what was mentioned. And then it makes what was initially thought to be an unresectable tumor potentially resectable. So we've had, you know, certainly even these days, there are actionable mutations, all these different EGFR and ALK and ROS mutations. The oncologists have all these fancy drugs, targeted therapies, and sometimes even neoadjuvant targeted therapy. You get a very, very impressive response, which then, you know, it's a lot of coordination. It highlights the point both my colleagues were making, that there has to be a multidisciplinary approach and discussion right from the start, and have a plan mapped out for the patient, so we can downsize and then at a predetermined interval go in and then do the surgery. So that's the premise, I guess, for neoadjuvant, you know, to downstage the tumor, increase the chances of resectability. With the adjuvant, just to mention that, again, there's strong evidence that, you know, even if the surgeon is able to fully remove the tumor, which is what we always set out to do, it's the systematic lymph node dissection, clearing out all the lymph nodes, which is very important. And then we await what the pathologist reports. And there can be microscopic disease that was not, you know, obvious on the pre-surgery scans, that wasn't picked up on a CT scan or a PET scan. And this is where the patient may benefit, even if the tumor is fully removed, what we refer to as a complete resection or clear margins. The patient, if they're fit enough, will then benefit from seeing an oncologist for adjuvant therapy, which is usually some form of chemotherapy or targeted immunotherapy, depending on the biology of the tumor. And again, the name of the game there is to reduce the chance of recurrence and micrometastases and give them that best chance of long-term survival.
Right, right. Doctor, I think on this session, we said we want to look a little bit at radiotherapy in a little more in depth, what little time we have, of course. What is this? What I was wondering about, maybe you can take us through a little bit of when you mean radiotherapy for the lung, Dr. To, what are we actually talking about?
Okay. Do we have the next slide, perhaps?
I think.
Yeah, okay. So I'll give you a real life example. Actually, what radiotherapy is using X-rays. X-rays are produced by, you know, linear accelerators. It's the same kind of X-rays you use for chest X-rays or CT scans, but those are kilovoltage, 10 to the power of 3. But when we use therapeutic X-rays, we ramp up the energy to 10 to the power of 6, and it becomes mega voltage, MV, huge doses. So when you use such huge doses, you have to be very, very, very precise and accurate. So our machines are designed to deliver the treatment just to the tumor and avoid the surrounding tissue. So with all the best will in the world, not every patient who has a lung cancer is able to undergo surgery, because, for example, this patient that I had in their 70s, he was diabetic, he had high blood pressure, he had previous myocardial infarction, he was turned down for surgery, yet he had a lung cancer which was potentially curable. So we designed a treatment plan for him using a technique called SBRT, or stereotactic meaning very accurate, body radiotherapy. Traditional radiotherapy is given in small doses over, let's say, 6 weeks. So daily they come, they get a little bit, a little bit, a little bit. The cure rates for that is quite poor. So we've designed a method to deliver all that dose of radiotherapy and compress it down to 4 or 5 sessions. So each session, they get an overwhelming dose of radiotherapy that the cancer cells have no chance to develop resistance, no chance to repair themselves, and they just die. But when you use such big doses, like you can see here, the tumor is right next to the mediastinum of the heart. So you have to be very, very careful. So our machines are designed to detect the patient's breathing pattern, their movement, and be very, very accurate. So the next slide shows, this was in 2015. After radiation, you know, we had a disappearance of the tumor in November 2015, but there was still a little bit of inflammation, and that inflammation can persist. And then in June 2016, the tumor had disappeared, and this patient is still alive in their 80s. So, in fact, we've done studies. We have a limited number of studies which show the effect of SBRT is equivalent to surgery. Equivalent. But surgery is still what we call the gold standard. SBRT is for people who are not fit to undergo surgery.
Right. Okay. Oh, and that's a good option. Dr. Darren, how is it in Sabah? Do you have the modality with you as well? Do you use it on patients? What is the kind of, when you speak about conventional radiotherapy and then you speak about SBRT, and then is there an option that you really offer to patients? Like, do you let them to choose? Do you choose for? I mean, we don't make a choice for them, but is the choice weighted in that sense? What do you think, doctor? What do you do?
Okay, so SBRT is an excellent technique for a limited number of lung cancers that cannot be operated because the patient is too elderly, for example. And the important thing also is that it is a limited stage disease. That means a very early cancer. What we have in East Malaysia, unfortunately, is a much higher or more advanced stage population, because patients in Malaysia tend to present late, and patients in East Malaysia are even further behind. And I'm sure later on, I'm sure you already talked about screening and things like that to bring that kind of staging earlier. But as it is, most of our patients present very late. So in East Malaysia, we hardly see patients who are suitable for SBRT, to be honest. If we do see one, we would refer to KL because we don't have the technology to do SBRT in East Malaysia at the moment. So we will be developing that as a next step. But there are other methods that we use. I don't know whether Kenneth can bring up some of my slides now on using different, more for later stage disease where we use techniques like intensive modulated radiotherapy, where we use techniques for later stage disease to try and avoid the lung and the heart and other normal organs using these sort of techniques. So other forms of techniques are more important for us in East Malaysia because of our later stage disease where SBRT is not so useful. I don't know, Kenneth, can you bring up some of the slides or not? If not, I will continue. Okay, next slide, please. Bring out the next one. The next one. The next one. Okay, so yeah, so this is a machine that Dr. To is talking about, a linear accelerator machine producing mega voltage X-rays, very high energy. We're talking about millions of volts as opposed to 240 volts in your electricity in your house. So these machines cost a lot of money. It costs about 10 to 20 million. And you can see little arms on the sites where we use to do a CT scan as we treat to target things as narrow as possible. And let me show you in the next slide on IMRT, just very quickly. So these are the MLCs, what we call collimators in the head of the X-ray machine to shape it. And let's show me the next slide just very quickly, where we can shape the fields to exactly the shape of the cancer to avoid the heart and other organs. Okay, so thank you very much.
Right, Dr. Aaron, sorry, just curious, just to share with the patients, and you can do this in real time, yeah? So while you're treating the patient, like the patient's right there, and then you can configure and then shoot.
We do it almost in real time, and some machines can do it in real time, where we do an image of the tumor moving as we breathe, and trying to shoot the tumor in the right position. So I think Dr. To might talk a little bit more about that in another slide. Is that right, Lyman?
Yeah, sure. Yeah.
Yeah. Yes, Dr. To, sorry, I'm just turning that back to you to continue on this.
Okay, maybe we can see the slides I prepared. Okay, this is just another example. Oops, maybe one back, of another patient who had very severe bronchiectasis and COPD. Again, definitely not fit for surgery. He had a tumor in the left side of the lung, which was treated. Next. So this is what we aim to achieve. You know, we want to focus down the colored area is the doses that we are doing. We're really focusing it down onto the tumor and avoiding the rest of the lung. Next slide. So this is a comparison of what Dr. Darren was talking about. On the left is what we used to do in olden days, where we used to deliver a lot of dose to the normal lung. The red part is where the dose is the maximum dose is supposed to be, followed by yellow and green and blue. So as you can see, there's a lot of low dose spillage onto the rest of the lung. Whereas on the right, you can see nowadays we have the technology to really focus the dose down onto the intended part of the lung. Next. So this is a patient I treated. We published this. On the left, you can see the tumor in white encompassed by the yellow area. But then as treatment went along, as the lung re-expanded, see the lung was collapsed before the treatment. As you treat, the air is able to enter the lung and it expands, and boom, the tumor has gone to the top. That white thing has gone to the top. And if you didn't do a CT scan during treatment, you would totally miss it. So that's why Dr. Darren mentioned that we must do daily checks on the tumor to be absolutely fastidious and precise with what we are doing every day. Next. Okay, so and the tumor moves. So the tumor doesn't stay in one position, it's a moving target. So it's easy to plan something in the brain. The brain, nothing moves. Whereas the lung moves all the time as you breathe. So next. So we have to make sure, oops, back one. We have to make sure we encompass all the possible positions the tumor can move. Next. And this is what we call gating. Sometimes we can gate. That means we only treat in certain positions. Or you ask the patient to hold the breath, and we monitor using a probe, and we only treat in certain positions of the breath hold technique. Next. Okay, that's all I have for you.
Okay, so I was going to ask you all, and maybe this either Dr. To or Dr. Darren can answer, because as you know, I always tend to ask all the weird questions that people ask me, and then this is probably the best forum for everyone to kind of break down some of those myths. So
questions come from brilliant minds.
No, unfortunately, it's for patients, but yes, brilliant minds of patients. So one of the kind of common complaints that we get is people are very unhappy when you give them these short, intense doses of radiotherapy. They feel that, we've had patients who move doctors because of this. They feel like, oh, this doctor is actually only prescribing me very little radio. I went and my friend told me you need a 6 weeks, 8 weeks, 12 weeks of chemo, of radio, when the doctor is telling me I only need 4 or 5 sessions, I think this doctor is no good. So I think I think could one of you all maybe take the kind of forefront to really make the difference and explain what I think Dr. To did it a little while ago, but kind of to re-put the point of that these are two different treatments and they have different kind of end outcomes in mind. Maybe Dr. To, maybe if
Okay, sure.
got you.
So the problem with spreading the treatment out over 6 weeks, 7 weeks, is that you're giving time for the tumor to develop resistance. So just like antibiotics, just like anything in any treatment you give a person, there's a chance that the thing you're treating, whether it's a bacteria or whether it's a cancer cell, if you don't kill it completely, but you're still exposing it to the drug or the radiotherapy, cancer cells are smart. They then develop a way to overcome the treatment. But if you give it an overwhelming dose of radiotherapy, there's no chance to develop resistance, that you just wipe it out completely without even giving it a chance to breathe. Then that method will give you much better results. And it's proven time and time again in many tumor types like the brain, the lung, you know. The problem is it safe to give such a high dose of treatment? So the safety factor comes into play. If it's not safe, I have no choice. I have to give it over 6 weeks, 7 weeks, you know, opian, no choice. But if it's safe, definitely I want to compress all my radiotherapy into finish within a week. Sometimes 1 day, 2 days, 3 days, finish it within a week.
Right. Oh, good. And that's really an important point to make to patients, that actually now shorter actually does mean better in terms of outcomes in most cases. Dr. Darren, and this is actually really a question that needs to be put to everyone, because radiotherapy still remains one of the, real bad guys in terms of cancer treatment, in terms of its reputation. Everybody is really scared of radiotherapy. Patients always will tell you, okay, I don't mind surgery, throw me some magic pill, but I don't want to do radiotherapy. In terms of radiotherapy for lung cancer especially, we get a lot of patients. I just spent about an hour this afternoon actually speaking to an individual with lung cancer who is still refusing radiotherapy because he feels his heart will be affected. So, doctor, please, if you can give us some insights on dispelling this kind of myths.
Okay, so I think it's horses for courses, or the right treatment needs to be given for the right condition and the right stage. So every person's condition and stage will need a different treatment. It's interesting, yeah, everyone is so well versed with surgery, because surgery, people all know what surgery is. And I think people don't know what radiation is. And that's why they get a little bit more, hesitant about radiation, because, radiation is this, you can't see, like COVID, you can't see, but it's always lurking around kind of thing. And radiation basically is what I tell my patients, is like having an X-ray. X-ray, like having a chest X-ray, is radiation. So when you tell them that it's the same sort of radiation that people get when they are having an X-ray, except it's stronger, and because it's stronger and higher energy, we need to target it well so that we target the right areas, shoot the bad guys, and leave the good guys like the heart and the lungs that are normal away from this radiation. And unfortunately, in the past, there has been a lot of bad reputation on radiation, because unfortunately in the past, not many radiation specialists were well trained, and people were just giving radiation, willy-nilly, treating the whole lung, right? Some patients I know from the past and also from the present, of doctors treating the entire lung, doing whole lung radiation, just giving the radiation all over the place. But I think with the modern technology available and the better training available nowadays, we can so target the treatment to hit the bad guy and leave the good guys away, just like an arcade or computer game that your children play nowadays, trying to hit the bad guy and not hitting the good guy. And by doing with the techniques that I and Dr. To have talked about, like intensity modulated radiation, bending x-rays to fit a little globe of tumor, using gating techniques or breath holding techniques where we follow the tumor so that we don't hit other unnecessary part of the lung. So we follow the tumor, just like target practice, just following the tumor. Techniques such as these have come leaps and bounds ahead. And with the combination of immune therapy and targeted therapy and chemotherapy, these treatments are so effective with very little or much less side effects than before, because we are sparing the good guys. Thank you.
Right.
One question that a lot of patients ask me is, during the radiation, am I radioactive? Yeah, so the answer is no, because the radiation actually comes from the machine head, hits the tumor, but once the machine is stopped, there's no more radiation in the body. It's not like a PET scan, for example, where the radiation is attached to a chemical and injected into the patient. So you're perfectly safe to, go and touch your baby and be with your pregnant wife after the radiation.
I blame a lot of this on Marvel. It's all the Spider-Man and the X-Men and the kind of various uses of gamma radiation in popular mythology. That's kind of put all these various weird ideas into people's head. Now, I'm just going to be naughty because I saw a slide from Dr. Darren, and maybe it's very appropriate that today, especially with, I actually didn't catch the 5 o'clock. I don't know how many cases are there today, but possibly if I could, 489 also. Wow. If I could catch all three of you gentlemen commenting each in turn on kind of in this setting with, again, the kind of rising number of patients, what is kind of your sharing to people who are, one, suspected of lung cancer, who are now very worried to get treated and come in for treatment? Two, what about those who are beginning treatment already or in between surgery, moving to radiotherapy? Maybe Dr. Darren had a slide, so maybe put it up. And then if I could get Dr. Anna and Dr. To kind of comment in turn.
Okay, so Kenneth, can you put up my first slide about COVID-19? So I think it's important to point out that the WHO is expecting about 2 million deaths from COVID-19. Very sad. But in terms of cancer deaths worldwide, in 2018, the WHO reported almost 10 million deaths from cancer, okay, across the world. Okay, so we cannot stop treating cancer, okay? If we just concentrate on COVID, we don't even have a treatment, a proper treatment or vaccine for COVID at the moment, okay? If we just use all our resources just for COVID, we will lose 10 million people or more this year from preventable and treatable cancers. So it's important. I wrote this article in FMT, and it's available there in that in FMT, and just Google it, tips for cancer patients. You must continue your prescribed life-saving cancer treatment. If you need to defer or postpone or whatever, discuss with your cancer specialist whether it is safe to do so or not. If you don't, the likelihood is that the tumor loses control. For example, if you only had 1 week of radiation out of 6 weeks course, it is worse than not having the treatment, because the cancer will then become crazy, it will spread, and it will be more difficult to treat later on. If there are treatments that you can get at home, For example, certain new modern treatments like targeted therapies are available in tablets or simple injections. Do ask your oncologist or your cancer specialist to give you those treatments at home so you don't have to keep coming out of the house. Of course, you must delay any non-essential follow-up visits. If they are non-essential, call up your doctor and say, can I postpone? And often they'll tell you, yes, please come back in 3 months or when the COVID numbers are settling. For example, in Sabah, I've stopped all follow-up appointments by face-to-face consultations and gone to virtual or telephone consultations. So if you develop chest symptoms that are worse than normal, if you're starting to cough things up, don't turn up to the hospital or clinic, call, arrange certain tests first before you come. And make sure you are doing the usual things, wearing a face mask, hand hygiene, and physical distancing. Attend appointments as much as possible alone if you can, and continue doing it on time by appointment basis. Malaysians are poor in setting appointments and keeping to that time. We need to learn to be different now. And if waiting areas are all full, you can do simple things like SMS, WhatsApp with the receptionist before your appointment. So you turn up immediately at your appointment time and then go and see your doctor and leave immediately. Okay, so some of the tips during this time, especially in Sabah where things are so bad.
Right, right. Dr. Anand, so what would you say? Definitely not put off cutting, right?
No, I echo what Dr. Darren was saying. I think, we've got to obviously be very fastidious and very meticulous and careful, all of us as a society, but as clinicians, especially, particularly with cancer patients. But we need a sense of perspective as well. I mean, you've heard the statistics there. At the end of the day, tragic as it is, the vast majority of cases of COVID will be asymptomatic or minimally symptomatic. Other illnesses and diseases aren't on pause. Cancers are going to progress. So patients or people who have suspected symptoms suggestive of a cancer, or those who have been diagnosed, they need to continue on their treatment journey, taking the necessary precautions. And it's what Darren was saying, liaise, discuss at length with their doctors in terms of the safest way to continue their treatment. I think it's, the pandemic is very unpredictable. It is not logical or feasible to halt cancer treatment and wait for this to pass, because that could be quite a while. And if someone has lung cancer, they will succumb to that before COVID, I think, as a general statement. Yeah.
Right. Right, and Dr. Anand, I've got 2 questions from the audience. I'm just going to ask them since I have you on the speaker. Side effects of lung surgery. What are the side effects that?
Okay, that's a very commonly asked question, a very pertinent question. So, if you recall, when I was talking a while ago, one of the things we have to always explain to patients is that unlike the liver or some other organs which have the potential to regenerate, when we excise or remove or resect the lung where the tumor is, that part of the lung is never going to grow back. But, having said that, we need one healthy lung is sufficient for a good quality of life. So one of the potential side effects, if we can call it a side effect or a sequelae, a consequence of lung cancer surgery, is they may, in the early postoperative period for a number of weeks or maybe a month or so, they may experience some limitation in terms of breathlessness or exercise tolerance, exercise capacity. But we work up the patients very meticulously, as best as we can with the various investigations I mentioned earlier in terms of trying to establish the operability of the patient. So usually we get it right. And the vast majority of patients will be able to resume a normal active lifestyle. And obviously, if we take a less invasive approach, then their recovery is quicker as well. That would be the main concern. Obviously, as with any surgery, whether it's conventional surgery or less invasive surgery, they can expect some degree of pain. But again, I kid you not, the vast majority of patients will go home with Panadol, paracetamol, and occasionally a bit of tramadol. And they're usually up at about pretty much back to normal within 2 to 4 weeks.
Right. And then there's another question as well on lung transplants. The question I think reads something like how feasible are lung transplants? Are they something which is even happening? Because the person goes on to ask which hospital offers it.
Yeah, I mean, in the context, this series we're discussing lung cancer, the short answer is no, it's not feasible for 2 reasons. Firstly, as a general comment, lung transplantation is, I think there's only one center that offers it here in Malaysia, but I think the main limitation is scarcity of donor organs. As a country, we have cultural issues with that. Everyone's happy to take an organ, but organ donation is very poorly highlighted. And I hope you can hear me, sorry. And certainly with any sort of organ transplantation, including lung transplantation, it's usually not an option when we're talking about cancer because of the need for immunosuppression to prevent organ rejection, and that will allow the cancer to flourish as well. Yeah.
Exactly. Dr. To, we kind of walked through Dr. Anand right up to post-surgery, and then perhaps some words on how radiotherapy can actually complement this. Is radiotherapy safe for lung cancer patients during this time? Some kind of input from you, sir.
Yeah, okay. So the critical thing with treating patients in this time is to make sure they do not have COVID before you start treatment. So whether they have surgery or radiotherapy or chemotherapy, if they have undiagnosed COVID, that can be fatal for that patient. So we have to test first before starting. That's my personal feeling or practice. Of course, there is a degree of immunosuppression when the patients are undergoing chemotherapy, for example. So patients need to be even more careful in terms of their avoidance of being in situations that they may expose them to the virus. There's some data from China that people who have lung cancer in itself causes immunosuppression. So cancer in itself, and also people undergoing chemotherapy, that there's a slightly higher risk of mortality if they catch COVID. So we have to design hospitals, we have to design the patient's environment such that they minimize contact and are in a safe environment. Exactly what Dr. Darren talked about appointments, about being careful, about having exercising common sense and safety in the hospital environment.
Right. Well done, Doctor. So I think in terms of questions that pretty much got all of us covered. And since we're coming up to the hour mark, actually, before we let people go ahead and start on their early dinners or actually middle dinner or whatever it is, maybe each of you gentlemen can take a few minutes and share with us some points that you want to take home from this session about surgery and radiotherapy for lung cancer. Maybe Dr. To can start, and then since we have you already, and Dr. Darren and Dr. Anand.
Okay, I think two points. One, radiotherapy has moved on a lot in the last decade, and we are now talking about a totally different way of treating patients. If you ever wondered what happened to the computer geeks in your class, they all ended up being radiation oncologists. Secondly, it's very important I cannot stress it enough, it's extremely important to have a multidisciplinary approach to treatment. So unfortunately in Malaysia, maybe some centers are not set up that way. But I think as a patient, if you do find that you have this unfortunate diagnosis of lung cancer, do not just confine your medical advice to one doctor or one specialty. It may be worthwhile speaking to an oncologist, a surgeon, to get a joint opinion as to what is the best approach for you. Hopefully, those are my two take-home messages.
Right. Dr. Darren?
In this time of COVID, do continue your cancer treatment if it is necessary. And if it's not necessary, please speak to your doctors and arrange a plan for home treatment if possible. And with that, I'm sure you will be safe and you will have your cancers treated by experts who will make sure that you will have the best chance of being cured from your lung cancer. And we are talking about cure nowadays on lung cancer, not just control or palliation. The latest figures we are getting, even for some of these stage 4 lung cancers, we are seeing people living up to 5 years, 20, 30% even now sometimes, with the latest treatment. So do not stop your treatment without talking to your doctors. Use the phone. Make sure that you change your habits to be careful and also to be on time with all your treatments. Thank you.
Right. And Dr. Ahmed.
Yeah, I think just to sum up, hopefully the viewers and listeners get this message that, optimal care really for any patient with lung cancer, for that matter, any cancer, we're talking about a multidisciplinary approach. I think what Dr. Thor alluded to earlier, there's a lot of decision-making that goes on. I think we're truly in the era of personalized medicine, not just with your targeted therapies and immunotherapy and chemo, but even with surgery. So no two people are the same, no two tumors are the same. Those decisions have to be made by a multidisciplinary team. That's good medical practice. And it should really be evidence-based, obviously. And, I think we're truly in that era of personalized medicine. So you have a bespoke treatment plan that is mapped out for the individual patient. And that may be surgery in conjunction with what we call as multimodal treatment with chemo, radio, immunotherapy, sometimes delivered before, sometimes delivered after the surgery. The objective, obviously, is to try and achieve a cure, or certainly a good quality of life for the patient. Yeah.
Mm-hmm. If I really could add my 2 cents into this, a lot of us, for those living in big cities like KL and all that, really, if you switch on, some of us think we know how to navigate a traffic jam, and we really suck at it. So every time you get stuck in a traffic jam, and then you just suffer for hours, especially when it rains in KL. Now, what you then do is you switch on your Waze. And I think what's important for a lot of people on their lung cancer journey, that when it comes to the part of treatment, you need a team of people. And Waze, as you know, is not one person sitting down on one computer, kind of feeding you on the phone, turn left, turn left. It's a series of people making decisions together and making those decisions to get you as quickly as you can to the place that you want to go, which is to a cure, without you getting into an accident and having all these side effects. So I think all 3 of these gentlemen have today put across this idea that, one, the treatment of lung cancer in terms of surgery, radiotherapy is not linear anymore. It's not point A then point B. It can be intermixed. It can come one after the other. It can come in between. And there's all these different modalities which now depend on every individual patient. However, it's not as simple as buying a Big Mac or spicy McChicken deluxe, however you want to put it. But the thing is, it needs to be done together by a team of physicians to kind of get at your cancer through a multi-modality approach. And that's really the thing. Today, I hope we've managed to kind of take away some of the bad rap given to radiotherapy. And thank you, gentlemen, for kind of putting that a little bit, I suppose, to rest. Again, really, thank you so much, Dr. Darren, for taking time across this evening, even in the midst of this horrific situation. I hope things get better very quickly. And to the rest of you all as well, for those who are tuning in, have a good evening and stay safe. Pretty much that's the only thing we seem to be able to do. And of course, do not neglect your cancer treatments. Thank you very much. Good night.
Stay safe, Dan.
Thank you, doctors.
Thank you, Ken.